Good. Hi, Jen. There you go. So I think you're mute.
Okay, hold on, I'm just going to start the slideshow here.
Yeah, no problem. I appreciate helping me with this.
Oh, no, absolutely.
I'm with my little computer right now. I'm like, oh, I miss my big monitors.
All right,
so
there's the slideshow.
Great, and we'll give a couple more minutes, right?
Yep.
You let me know when it's time to roll on.
Okay, you guys are going to have to let me know because I cannot see the panel when I have the slideshow up. So you guys are going to have to tell me.
Okay, it's one more minute.
Yep, okay. All right. Why don't we start about 1 minute after? Because it usually, sometimes people are jumping off one meeting and then on to another one. So let's start.
Perfect. We'll do that.
Okay.
Thank you.
Yeah. Okay. I got a little problem here. Hold on. Gonna end that really quick and I'm gonna do something different. I'm gonna stop sharing if I can get back here. Hold on, I'm gonna do something different. Hold on 1 second. Hi, Katinka. I'm gonna ask Lori to share them. Because then I can see the. One sec. Guys, we're going to get going in just a minute. We're still waiting for people to log on.
Can I have up? Let me know if when you can see my screen.
You do have them up?
Yeah.
Oh,
let me know when
you
you can
heard me
see my
talking.
Yeah.
Wow. Okay. Thank you. Perfect. We can see your screen if you want to start the slideshow. They're perfect. Excellent. Then I can actually see that's terrific.
That's
It's
great.
one of the downfalls of Teams is that it's hard to do both. So, all right. We are just going to wait for about one more minute. We have about 9 people on. We're almost there.
Can you see and hear me? Cindy Hansen?
Yes.
I'm just trying stuff. Okay. So I opened up my camera and my mic and I'm going to mute my mic now, right?
Yep. Okay. You guys, should we get going?
Sure, let's do this.
All righty. I am going to get back to here. Lori's gonna be showing her slides. Okay, everybody, welcome to the October session of the Integrated Behavioral Health Training Series. I'm going to turn off my camera and turn it over to our fantastic trainer, Martha.
Thank you so
let me know
much,
if you need
guys.
anything, Martha. Yeah, and Lori's
Yeah.
in the background running your slides for you.
Great, I appreciate it. So thank you. So everyone, you're probably going to recognize I have a different background, and it's because I am right now in Boise, Idaho. Tomorrow, we're starting our CFHA annual conference, and I'm very excited because it's actually the first time we're going to be in person after 2 years doing this online due to COVID. So I'm in a different environment. So I appreciate all the technology support FQHC is giving, WCHQ is giving me. And today also I have here just behind me my colleague Julie, who is part of our TA program as well. So let's start our presentation of today about consulting psychiatry inside and outside of COCM. I have my chat here open, so if you have any questions, feel free to write them on the chat or unmute yourself if that sounds, if that works for you guys. Okay, we can go to our first slide. So I know in the beginning, so I think it was 7 months ago when we started this journey with all of you, we kind of show this slide, and I'm just going to take a very few moments to kind of remind you all of what it's really COCM really quick, because again, this was explained in our first sessions. So this is I'm a very visual person. So this is a tree that really helps. If you check on the roots, there's a lot of different perspectives that we use in our settings. Then you're gonna see the clinical pathways that there's a couple of them, but then the models. So the PCBH model is the one that we have kind of talking a lot throughout our sessions and how to really means to be integrated. What does an integrated service means? It's not just having mental health people in the same building or working with providers, but it's mainly working as a team. And we have been talking about it. But today we're going to talk about the collaborative care model. We can go to the next session, then next slide, sorry. And really, that collaborative care model, it's a systemic approach to the treatment of depression and anxiety in primary care setting. What this means is that it's very important as a site that you really question yourself, what is my site trying to solve? What question we're making? And if you find that one of the questions you're making is like, we want to improve the patient care for those who have depression and anxiety, then COCM might be the model that you want to follow. However, when I created this presentation about outside COCM, it's because a lot of the times we do find that we have some psychiatry needs or our patients need that, and not necessarily you need to follow the path of the COCM model, but you can do things that are kind of parallel or similar and have support. But I think the main thing you have to ask yourself is, what is the question I want my site to answer? Now, again, if you really want to track a number of patients who are coming high in depression and anxiety and see how you can best support them, COCM will be probably the model that you want to use, right? So it works very integrated with a BHC manager, a primary care doctor, and a consulting psychiatry. And I'm going to explain the roles of people because it's different. It's different what we think it means to, oh, my patient is going to be seeing a psychiatry. It looks a little bit different. It's within primary care physician oversight to having a more proactive manage of those mental health, but particularly to kind of be able to solve a problem before it becomes chronic. So it's like being proactive about a particular panel of patients. We can go to the next slide. So it focuses on definitely like a patient population tracking registers. You're gonna track those patients with time and see how those symptoms are improving and what things you're gonna be doing with them, very targeted to see if those symptoms are improved. So you'll have these kind of bucket of patients who are coming high in depression and anxiety. You're gonna track them. You're gonna do very specific things with them. And you're gonna be, kind of checking symptoms with time with the goal to kind of help them improve the symptoms. It's usually trained in primary care with primary care providers in the same building. So again, we need to have the team working together. It's not about sending patients to another department or another clinic. And the psychiatrist is going to be someone who's going to consult. And I'm going to talk a little bit more about that, about what does it means to be a consultation with a psychiatrist. We can go to the next slide. So this triangle, I think it's very helpful to kind of understand who's, everyone in the role of this when you're kind of implementing COCM, who's going to be involved. So we have the patient in the middle. If you can see on the top of the triangle, it's the medical provider who's going to be having direct contact with that patient. And then we have on the side below on our left, the behavioral health care manager. Now, this role, it's someone who's going to be tracking information, but also providing behavioral health helpful instructions to the patient, like if they're dealing with depression or anxiety, like what about starting a routine of exercise or teaching breathing exercises. So they're going to be implementing some behavioral strategies to the patient, like work with the patient, but also tracking some numbers. Some clinics, what they would do is that they will have the BHC person who is usually seeing that patient for behavioral strategies, and they have another person called behavioral health care manager, which is mainly someone that can be used like a social worker without clinical license, and it's really just tracking the numbers of the symptoms if they're improving and just checking that appointments are happening and making really quick phone calls with the patient. So that BHC care manager can be one BHC doing both roles or two of them, one being very clinical expertise and the other one more like the word that's more managing the case of that patient or the loads of patients that you're going to be tracking. You can see the lines are kind of like, they're frequent contacts. So it's a straight line between the patient, the provider, and the BHCs, right? Now we have in the other corner the consulting psychiatry, and those lines are kind of interrupted because that means that the patient will have contact with the psychiatry not very often, once every 3 months maybe, if needed. And then also the psychiatry will have some contact with the medical provider, but not very often, right? And then the register means, again, it's just that data that you're going to be keeping track of the patient. So this is a model of who's involved in the collaborative care model, who are going to be working with who, and just explains who's going to have more contact with who. We can go to the next slide. Now, this is a skeleton, as an example of how you can create a register. So if you guys decide, you know what, in our clinic, one of the questions is that we do kind of, for example, at this point, implementing PHQ-9s already. And we really want to help those patients who are coming really high. and track them very often and see if we can help with those symptoms and reduce the number of the PHQ-9. If that's the case, it's very important that you create a flow of how that's going to work. So the first step is actually just screening your patients. And whoever, come higher, and then this is also, that's where it comes here to the score cutoff. So this will be a clinical decision or a clinic decision, a system decision of what number of a PHQ-9 you guys are going to decide, okay, whoever comes above 12 or 15, that automatically is going to go to our COCM model, right? So for your screen, then whoever comes higher of that number that you guys have decided on those screener will go directly to that bucket of patients that you're going to be starting following more closer. You identify those patients and then create the register, which means you got to start, those names will be there. Some clinics, their medical records are not as advanced. So then that register starts really like in Excel sheet, like the names, the date of the PHQ-9, what was the score. And then you're gonna kind of, start a process. Okay, so first, what's that flow is gonna look like? Does this patient, because he come higher, will first have a meeting with the BHG team, and then probably go and see psychiatry, and then the provider. How does that gonna look like? So that flow, it's important that you guys, decide how it's gonna look in the clinic. And later on my slides, I'm gonna give an example of 2 clinics for actually kind of how their flow looks like, so you have an idea. And then you have to record that work, right? So what were the things that were implemented or you were doing with that particular patient? And then just reporting if their PHQ-9s got improved or better, right? And you keep tracking that. So it's very systematic. It's very data oriented, and you can actually start seeing, right away results, okay? So this is just an example of how you can create that register, right? Again, this is when we're talking about, yes, one of the questions we want to answer in our site is we have a lot of people who or all are being screened with PHQ-9s, and I think it'll be helpful to start helping those particular patients that come high in PHQ-9, right? That's kind of the inside of COCM. That this is usually kind of the process. It's very step 1, step 2, step 3, very, very straightforward. Okay, let's go to the next. Now, the consulting psychiatry that we describe or that we have in that kind of triangle, it has to be someone that really gets it. And when I said consultant psychiatry, it's because they really need to know how the primary care flow or life goes in the clinic, right? And also educate the providers, because a lot of the times there's the misconception that, oh, the clinic is going to hire a new consulting psychiatry. So then they assume that patients are going to be sent with that psychiatry and is going to be seen as a regular psychiatry. So that patient is going to be seen the psychiatry maybe once a month, and now the primary care doctor will hardly see that patient again. That's not what we want. A consultant psychiatry, and the word says consulting, it's really gonna see the patient once and is gonna provide some feedback to the primary care doctor. But the person who will continue seeing that patient more often will be the primary care doctor. You remember the triangle in my couple slides before, that those lines were straight because the contact with the patient and the PCP, that's gonna be the often, contact there. Not too much with psychiatry, right? So it's very important that we clarify this, because a lot of the times there's a misconception that if, oh, there's going to be a new psychiatrist in the clinic, then now the psychiatrist is going to take care of those patients. Now, the reason we don't want to do that in primary care is because it will happen the same with mental health struggles. The waiting list is going to be long, that psychiatrist is going to be overwhelmed, many patients, and we want it kind of to be in the middle. Now, there's going to be some patients that might require more intensive psychiatry care. And if that's the case, most likely those patients don't belong to be seen for their psychiatry care in the primary care, the primary care clinic. So they need to be referred outside in the community. Now, when we talk about the outside of COCM, when we can have a psychiatry that supports the team, sometimes that psychiatry can be helpful as bridging. So bridging those services while that patient is being seen outside in a more specialty care setting. But in or outside of COCM, that means if you're really going to create a register just to track people with depression and anxiety, or if you're saying, no, we just want to copy a couple of things of COCM to more like have a consultant psychiatrist that supports our group of doctors in the clinic, either or that way, you have to keep in mind that it's a consulting role what the psychiatrist is going to be doing. Okay? And understand the limitations. Like I said, there's going to be some patients that they need that probably follow with psychiatry once a month and more, close follow-ups, and their care needs more specialty care. And if that's the case, it's important to set that boundary and kind of refer them out in the community. We can go to the next slide. Now, how do we find the correct providers? Well, one of the things that we do a lot in our consultation service, it's actually been involved in the interview process and kind of explaining this to psychiatry. But it's important that the team who's even going to hire that psychiatry, or if the clinic decides to make that change and the psychiatrists are in the clinic, they really understand what this will look like, right? Because it's important that they have a fidelity to what really primary care is and what is the mission of working in a consulting role. At the end of the day, it goes back to very much what we have described in our sessions before. It's a team approach, right? So psychiatry will provide some suggestions to the primary care doctor. The primary care doctor, together with your behavioral health team, continue to work with that patient, but it's a team approach. So everyone is supporting each other, right? It's not about sending someone to psychiatry and then the psychiatrist isolated with that patient. We continue to reinforce that team approach, which it really reinforces the best way to kind of support patients in their care. We can go to the next slide. So here, this is actually a flow of, I will call it the outside of COCM, okay? So the inside was, again, you make, or your clinic made the decision of track a particular number of patients to improve depressive anxiety symptoms, right? You create the register, the names, like I said, very data-oriented, and you're gonna follow up those steps of COCM, following them with phone calls every 2 weeks, giving them very direct instructions of what to do, monitor medication, follow up if they're taking their medication or not, and then bring them back with behavioral strategies and keep tracking those PHQ-9s to see if those scores get lower. That's very much COCM. So that's inside COCM, okay? The outside, it's what I'm explaining right now. It's the idea of, wow, it's great to help patients and that we have a psychiatry on board, but what if it's not about depression and anxiety? What if it's not necessarily about that PHQ-9 that comes higher? Can we have a psychiatrist in our team that can support the medical team and the patient care without that tracking? Yes, it is possible. And I will tell you that that's exactly what we start doing in the clinic that I work in Wisconsin. So this is a flow in which what happened was we still have it. It's a psychiatry that got hired for our team, but with the consulting role, right? So anytime a patient will come and see their primary care doctor, and the primary care doctor realize, okay, this is a patient that has health conditions. Let's say maybe they just had a stroke and they're having a lot of medical, conditions, but they need psychological medication as well because of whatever, they have a mood disorder or anything like that. And the primary care doctor, again, due to their training that they are not sure if the mental health medication will overlap or be helpful or not with their health issues. Is they're gonna probably increase their cholesterol or any other labs that will be effective and that maybe it will not be helpful. When they encounter those type of questions, that's when it's helpful to have a consulting psychiatry on board, because then the next role will be, which is the second bubble that we see in this kind of flow, the primary care doctor will come to the BHC person and say, guess what? I have these patients who are struggling with a lot of health issues, but they really need also mental health medications because they're dealing with mental health struggles as well. I don't know how to do this. I don't know how to manage medications. What do we do? So in our team, what we do is we check the case, and sometimes we, as a BHC, for our own expertise, we're able to answer the questions the provider has. But other times we don't, right? So when we are unable to answer the question, what we do is we refer that patient to a consultant psychiatry. And the way that we do it is that we created a very specific template to kind of normalize and kind of centralize all the questions that we need to answer for that, in that case, and that template gets sent to the psychiatry. And then there's two options. Maybe the question that the provider is doing is very simple as to, should I increase medication or decrease medication? And if it is very straightforward, then we do a written consultation. So that written consultation is very specific, written, and send it to the psychiatry. The psychiatry will review it and will reply to the primary care doctor of that patient and the BHC patient. And then the primary care doctor reads those recommendations and said, oh, okay, I know how I can do this. I know I have to decrease this medication, but increase that one, and then maybe check labs, and then continue doing some changes. So based on what the consulting psychiatry told that doctor to do in the recommendation, right? So then after the doctor receives that recommendation, we'll contact the patient and we'll do those step-by-step recommendations that the psychiatry did with the patient, right? But again, if you really think about it, the consulting psychiatry didn't even see the patient. So you don't need to, it was just written, it was very easy. Now there's other cases in which, if we turn to the right in this diagram, it was needed due to the questions that provider had, that the patient sees that consulting psychiatry face-to-face. Now that's usually a 45-minute session. There's, again, a template that was answered before that appointment, which the BHC team helps kind of make those questions to the patient. So the consulting psychiatry has some information of the history of the patient. And of course, the main thing is the question the provider has. So again, the consulting psychiatry is really supporting the PCP with that question that the PCP is unable to answer, right? So then the patient will come see the consulting psychiatry. The consulting psychiatry will check the patient, go through his history, and then after seeing the patient, we'll make some recommendations and we'll tell the patient, now you need to follow with your provider, and I will tell your provider what are the recommendations that will be given, and your medical doctor will continue with those recommendations. And then usually that patient will not see the psychiatry anymore unless things got worse or something happened that, there's more questions to answer or to resolve. But for the most of the cases, that patient will see the consultant psychiatry once, give the recommendations to the provider, and the patient continues to see the provider following up the recommendations that the consulting psychiatry did. So that's this kind of role. Can we go to the next slide, please? Next slide. Great, thank you. So if you really, sorry, the one before, sorry. Okay, if you really look at this other part, it's that what I kind of just described. When it's a written consultation, it's the BHC team who does it, just kind of, and the reason why we do it is because I think it's important that when the consultant psychiatry review that written intake, it's all centralized, like that our psychiatry knows where to find the question that we're trying to answer for the patient. What is the history? What medications they have tried? or what happened in the health history of the patient. So that's very helpful because we are 11 on the team. And if all of us will do our own thing, it will be very time consuming for the consultant psychiatry to understand what's going on. So I am a big advocate for templates because it just kind of put things the same way for everyone, and it's easier. It's very time saving for not just the BHC, but the providers and also a consultant psychiatry. So this is kind of the second part of the role. If it's written, was what happened. If it's in person, when the psychiatrist sees the person face to face, what happens, right? And then, like I said, the follow-ups are as needed, but it's not like traditionally having a psychiatry on board in your site, in which usually the patient will see that patient over and over. So if you really think about this, it's important that the message, it's well communicated across the board, not just with the team in the clinic. So the providers will know what's really the expectation of the consulting psychiatry. The consulting psychiatry knows also what is their role. Again, they're consulting, they have to give recommendations to the provider. And our consulting psychiatry does a really good job because she even will say, try this. And if it doesn't work, then try that. So it gives kind of different recommendations to assume that maybe she's not going to be able to see that patient again and to provide as much information to the provider. So again, it's important to educate the staff, and that means the medical providers, the consulting psychiatry, your BHC team, so everybody knows what is the role. But also, it's very important to educate the patient and the community. Because sometimes patients, when they hear the word psychiatry, they're coming from other experiences in which they were seeing psychiatry once a month, and then they're going to be like, why I'm not seeing psychiatry again? You guys have psychiatry services. No, wait, it's different. It's consulting psychiatry. So it's very important that since the beginning, we explain to the patients how the consulting psychiatry model looks in your clinic. And that's if you have COCM or no COCM and just have a consultant psychiatry supporting your team. Okay. Now, when I said in the community too, because some other places where you're located can assume, oh, your clinic has psychiatry, so they have psychiatry services. And then they start sending you a lot of patients for psychiatry services when it's not really what you have. You don't have psychiatry services. You have a consulting psychiatry who works together with your team to best support that patient care. Okay. So again, if you decided this is great, I think we will start in our clinic, or we are already starting it, really review the education about if everybody knows the role for that psychiatry. Okay. We can go to the next slide. Now, in this is, so the two slides that I just shared before, that's actually the flow that we use, and I said in the clinic in Wisconsin, and it's not COCM, it's not inside COCM, it's actually outside COCM. So the idea of bringing our consultant psychiatry to the team was with the goal of we need a psychiatry that supports our PCPs, and she's been doing that for years. The cool thing is that now that it seems like there's some changes about COCM billing and all that in Wisconsin, because we have been doing this for years, against outside COCM, there's the thinking that, well, now that it seems like in the state, we're probably going to start billing for some patients for COCM. It's easier, that transition. It's easier the transition to say, okay, we're going to continue with our outside COCM, but because we do screen patients with PHQ-9s, we're gonna start doing the COCM. We're gonna actually start tracking those who come up really high and start following with them routinely, and we'll implement COCM, right? So that's a cool thing to have it already in clinic. But I think the main thing that you have to ask yourself, it's what is the question I'm trying to answer for my site? So a lot of the times we jump into that we want more revenue, we want billing, oh, another bill to code. and you're going the other way, right? It's not necessarily that you're answering a question that your site has. It's more about revenue. And then there's a lot of obstacles and block roads because you're working things backwards. But if you start with the idea of our providers, for example, are struggling a lot with patients who are coming with mental health struggles and they don't know how to manage medications, and you start answering those questions, then you start working the right way, okay? So again, I will say that the two other slides that I shared, it's because we started to do outside COCM, so really having a consultant psychiatry on board, and even not even thinking about the billing. It was more about how can we best support our providers and give better care to the patients. Now this slide here, it's another side that shared, and they actually did like a flow. If you see the left column, which is the blue on the top, it's a flow for their team, the BHC team, to understand how to see patients when they really don't fall into that criteria of COCM. And the kind of right column, which is the yellow, it's kind of the flow for those patients who actually, they fall in the criteria for COCM. So if you see the first part is the reason for service. So if it's usually a BHC consultation, it describes those type of things. It's for mood, disturbance, ADHD, substance abuse, psychosis, complex multi-diagnosed presentations, any social emotional problems, safety. So all that the BHC will be like a consultation for a regular BHC session, right? Now, if it's because it's a patient who came out higher in a PHQ-9, then it bumps to, oh, this is someone that we might gonna start seeing in the COCM, role. So this is actually a flow of a clinic that had, they're working both, but in order to make it clear again for their own team, they make this kind of map, if I can say it that way, just to make it clear. And then below it says the description of the support, so how they're gonna do that support. So if it's a regular BHC thing, usually sessions are between 1 and 4, they're warm handoffs, you are available at the time, so how that look like. But if it's someone who actually went to the COCM list, then it's a care management will be giving calls, and it's a different role and different approach that they're gonna have with these patients, okay? So really the difference started in the beginning with if it's a PHQ-9 high, and if they go to that list, then that approach is gonna look different. Then they included the staff who's involved on those roles just for a regular BHC consult or a COCM. And then they kind of share here some of their both included consent forms and follow-ups and just like their own routine. And the idea I wanted to share this in this presentation with all of you, it's because I just want for you to see that these are two very different flows for clinics, but that the important thing is that it's written, right? So it's elaborated per the clinic needs. So if you're thinking, oh, I would like to start in my clinic COCM either the inside or the outside way, it's very important that you check your clinic flow and create something that it's clear to educate your staff. And also that information will be helpful for your staff to communicate the patients. Because remember, I think integrated care is still misunderstood, and a lot of the people, when they come to an integrated care setting, either if it's just to see someone in the BHC team or psychiatry, they automatically think, oh, I'm gonna get specialty care, traditional 1-hour session with my psychologist. And that's how they interpreted the role of the BHC. Or they interpret, oh, I'm gonna see my psychiatry like I was doing at my other medical center. I'm gonna see my psychiatry every month. And it's different. So it all starts with the education. So the expectations on your staff in clinic, but also with patients, it's very clear. Now let's go to the fun part. We can go to the next slide. which is the billing codes. And like I mentioned, I kind of share some of the most used billing codes for COCM. So that's if you really want to go inside of COCM. And below, I had a link that you can go and click later and explore it. But I can tell you again, in the state of Wisconsin, we're just starting to kind of change this, and we're still figuring out which codes are going to apply and which ones don't. I will highly recommend don't focus on the revenue, but more about how we can best support the clinic depending on the clinic needs. And based on that, it's easier that whatever flow you create, if it's reimbursed or not, depending on what's the case, it's really that you are helping your teams to function better. And automatically by doing that in clinic, then the benefit is on the patient, right? It's like I explained our case when we in the clinic, I think it was probably 12 years ago when consulting psychiatry started to work with us in the clinic. There was not even words about COCM. COCM was so like green, probably nobody knew about it, but it was because we realized how can we best support our medical doctors in the clinic. There are things that they are struggling where they are taking care of the patients, and not necessarily that the patient will need very intense psychiatry services, but it's kind of that in the middle. There's medical providers are stuck. They don't know which recommendations to do, and they're sending patients to psychiatry, which there are very long waiting lists. So what do we do? And that's when, like I said, we brought our consultant psychiatry, and this person started working just phenomenal, like giving recommendations. And it's been years that we've been doing that, but again, to support the team better. And now that maybe COCM will change, we might do that transition and it's going to look easier. But it started more with what need does the site has, and we can improve that, right? Okay, so again, here are the codes that if you are interested, you can review them later. If you actually want to do COCM. In my next slide, I added actually an additional reading that if you just click to it, I think will be helpful in just to kind of share why it's so important, the perspective of having a consultant psychiatry on site. What are the benefits? What are the all those important things that can support the team. I also want to add, I really am not aware of how many people here listening to us today are CFHA members, but because COCM it's starting to kind of wake up a lot. If you are a CFHA member, there's actually a group, it's called COCM Working Group, which is basically people from all the nation, United States, passionate about COCM, and they meet once a month to discuss things like, what do we do if your state doesn't cover billing, but we want to start it, or we're going to start it and we have some roadblocks, what do we do? So they brainstorm ideas as to how to get this rolling, talking about inside COCM, right? So if you are a member of CFHA, you can reach out to me, send me an email, and I can gladly include you to that working group. You can, it's informal in the way that you can join the meetings when you can. You don't have to if you're busy or working or whatever. But the cool thing is that you start getting network with people who are actually already doing it in other states, others who are just starting to do it, and just get a lot of feedback and perspective if this is something that you guys want to pursue. So that's an option there. Questions about billing and state, and again, just like the networking, it's helpful. If you're not a member of CFHA, you're like, well, whether that means how much the membership and all that, you can also reach out to me and I can explain you, and then you can make that decision. But again, those I think are resources that we have inside CFHA that you can, take advantage of them. But yeah, I want to open it for any questions. And we have the code as usual for you guys to kind of get the accreditation of this meeting. any questions, comments, and also just to remind you guys, we have been supporting some sites one-on-one. The way to best do that, either contact Jen and she will direct that information to us, or just email me and we can set up that appointment. It has been very helpful for those sites that we have been meeting one-on-one, because like I said, each site has different questions to answer, different needs, different situations. So this information that we're providing, please know that it's like a general thing. But if you're like, well, that sounds great, but how would that look like on my site? Then we might probably need to talk one-on-one and we can give you those suggestions.
Excellent presentation. Any questions? Anybody have questions today?
I have to add also that in our intention to, like I said, educate well our staff and our patients of the services they're getting, a very important piece, if you don't have psychiatry in your clinic, it's that job description. Like, how are you going to post, if you want to hire a consultant psychiatry, how are you going to hire that psychiatry? And it really starts with the job description of who do you want to recruit. Believe it or not, it all starts with that. Even if you want to start even hire a new BHC, it's very important how you posted that. You really want to communicate a clear language that it's a primary care setting, that it's consultation, and how that will look like. The job descriptions, they look so different from someone who has traditional mental health experience. And you're hiring the same licensures, right? But it has to be a different lens of how they're seeing that. If, again, that's something that you need support or help, that's part of our role as one-on-one, support to all of you guys, sharing job description, reviewing, giving you some insight about salaries and all that as well.
And everybody, I'm going to put, if nobody has questions, I'm going to put in the chat right now a link to our upcoming Disparity Summit, which will be taking place in Brookfield. It is free to anybody who is a WCHQ member or anyone who's not. Typically, WCHQ events are for members. This event, anybody can come. So all you have to do is go to our page and look at education, and we are going to have a full day Disparities Summit next month in Brookfield. It's going to be an excellent day with national and local speakers who are passionate about health disparities in Wisconsin and nationally. The QR code said the survey is already expired. Oh, maybe that's odd. Okay, thanks, Anne.
Yeah, I will leave that up to you, Jen.
Okay, yep, we'll figure that out. But you don't have to scan the QR code, you guys, if you're here. I keep attendance if you're actually here. The QR code is if you are joining later, and it is MCW that actually did the QR code, so I'll chat with them about that. But please do share the link to the Disparity Summit and join us for that next month in Brookfield. Does anybody have any comments, questions, anything else before we end and give you 15 minutes back in your day? No. All right, I know how busy everybody is. You guys are fantastic. Keep an eye out for the follow-up email. Martha, as usual, terrific presentation. Thank you so much for everything. And please do take Martha up on the offer to do one-on-one. It's excellent. Thank you guys so much and have a great day.
Thank you, Jen. Happy weekend.
All right, have a terrific conference, Martha.
Thank you.
Yeah, I hope it's great.
Thank you.
Bye, everyone.
Bye-bye.